Fantastic. Thank you very much indeed. And I need to start with a little bit of an apology. That is, I'm traveling at the moment, so I am going to have to juggle this a little bit. I'm just at the Pathology and Diagnostic Show in Birmingham, and it really has been the most remarkable insight to what's going on here. And I'd love to tell you about it another time. But before I do that, what I really want to do is to introduce our speakers. Professor Chris Ham, co-chair of the NHS Assembly, Paul Maubach, chief executive of the Black Country in West Birmingham, CCG, and Professor Jane Perry, Dean of Health, Sport and Bioscience at the University of East London, and Richard Darch, chief executive of Archus. Mike, would it be right to hand over to you to administer the speaking element of this?
If that's what you wish to do it, James, that's absolutely fine. Thank you very much for that. Could we please have Professor Sir Chris to go first, please? I believe you're on mute, if that's any help at all.
Okay, thank you. Can you hear me now?
We can hear you now. Thank you very much.
Well, thanks for asking me. I think we've got 5 minutes each, so I will be succinct and to the point. Starting point for me of this is we had a clear and loud message from the pandemic, the challenges facing the NHS and social care and public health in terms of the lack of capacity to respond to a national emergency on the scale of COVID-19. I saw that from the national role I have as a chair of an integrated care system and also on the board of the Royal Free London Hospitals Foundation Trust. And in a way, that was not a surprise because the NHS has always run hot, and we've had a decade or so of austerity where growth in funding has not really kept pace with the growth in demand and need in the population, and that's made the underlying shortage of capacity somewhat worse. We also know from international comparisons that the UK for some time has had fewer doctors and nurses per capita and also fewer hospital beds than many other countries, certainly if you look in Western Europe and to some extent further afield, which means we lack a buffer to respond to surges in demand of the kind that started in 2020, and hopefully we're now moving beyond. Pre-pandemic, it wasn't so obvious that there were capacity constraints in public health, but quickly they became clear. We didn't have sufficient capacity for community testing, which was why that was suspended as early as March 2020. And we didn't have enough capacity for contact tracing. That was woefully inadequate until there was an investment of money, of time to correct that. But in the process, a number of mistakes were made along the way, particularly overlooking the valuable contact tracing capacity we had in local government until that was corrected. So I hope future pandemic planning is already acting on these lessons from the last 2 years. I hope too that the Treasury is willing to take the necessary actions, recognize that having some spare capacity is not a sign of waste. It's often seen to be the case in the past. That has been the Treasury view. That spare capacity really is the result of prudent planning, recognizing the value of having a buffer to deal with those surges in demand. And we need, therefore, a funding system for the NHS social care and public health that makes this possible. If you go back, then the evidence given by Sally Davis, Mark Sedwell, and Oliver Letwin to the joint inquiry by the Science and Technology and Health and Social Care committees, they were in agreement that immediate pressures in public services often crowd out the resources that we need to make an investment as an insurance policy for the future to build that buffer and that spare capacity, or putting it more succinctly, short-termism trumps long-term thinking and long-term planning, and we've suffered the consequences of that during the pandemic. The broader point here is that our institutional arrangements in government for managing risks have also been found wanting. The way I would summarize this is we have a highly centralized system of government in the UK, but paradoxically, we have a weak centre. And that's been exposed in the shortcomings of the Cabinet Office and the Civil Contingency Secretariat, both in the planning and the work on managing national risks, but also in the more immediate responses to the pandemic. So the issues we're talking about in relation to capacity aren't just for the Department of Health and Social Care, or indeed NHS England. This is a whole of government responsibility if we're going to learn the lessons, get it right, and never again find ourselves in the position we are in today. And of course, the NHS and other public services did respond with agility and flexibility in a position they found themselves in. They were able to build at pace the Nightingale hospitals. They were able to convert existing hospital accommodation to create the surge capacity in intensive care. And that meant that we were never overwhelmed as far as the NHS is concerned in the way that we saw early on in countries like Italy. We were able to avoid it, but it was a close run thing. And I think that's a key lesson we must take. And if there's one area, and perhaps I can finish on this point, one area above all where we need to move quickly, it's in relation to the staffing available for health and for social care. Pre-pandemic, there were over 100,000 vacancies within the NHS. The majority of them were in nursing. To go into a pandemic with that scale of vacancies obviously was in itself a problem. And as yet, we've yet to see a credible and fully funded workforce plan for the NHS to come forward from the government. Think tanks and select committees have made this point repeatedly. I think there's a broad consensus across the political spectrum that this has to be the #1 priority. We can't deliver in normal times what is needed in the NHS, let alone during a national emergency like the coronavirus pandemic. So that for me would be the most important priority. But in addition, of course, the infrastructure that we need, whether it's buildings and equipment and the buffer that I've referred to, that needs a whole of government response. And we need to act very quickly to make sure that's in place.
That's great. Thank you very much, Sir Chris. Can I hand over to Paul Maubach now, please?
Thank you. So first of all, I'd agree with everything that Chris has just said. I think particularly during the height of the pandemic, we were as an example, we were monitoring ventilator capacity by the hour, and we were on a knife edge in terms of being able to have sufficient provision to meet the needs at its peak. But the Minister of State for Health, when he kind of initiated this review, one of the things he said, which I agree with, is that if we're going to learn the lessons from the pandemic, we need to not just look at what's needed in acute settings, but across the whole system, including primary and community services. And the first version of the health improvement plan, investment plan, was particularly focused on hospital investment. And I think one of the key issues that we need to consider is, well, what are the needs of the whole system in terms of what are the investment needs across the whole all services. And I particularly want to just in the next few minutes just focus on that. I'll give you 4 key points in relation to primary care, because one of the key lessons from the pandemic is that it's the most deprived communities that were hit the worst and affected the worst, and health inequalities have been exacerbated and worsened as a consequence of the pandemic. Part of the solutions to redressing that inequality gap is in making sure we make the right investments in the right communities that need it most, particularly in out-of-hospital care, in order to maximise the opportunity for ongoing prevention and reducing unnecessary admissions into hospital. But there are 4 questions that I've got, 4 issues that I think it's worth considering. The first one is the original health investment plan was focused on the acute sector, and there are, in addition to the original 6, there are 21 hospitals in the pipeline. So is in this process, is there going to be sufficient funding to support the non-acute sector as well? I think, and are we going to be able to get the right balance of investment between what is absolutely needed in the hospital sector, but what is also needed elsewhere? I think that's quite a challenge. The second key issue for me is that there are real difficulties with the current capital funding model for primary care. So we're very dependent on, from a planning perspective, on the willingness of general GP practices to want to participate in those capital developments. So if you have practices that are in an area which you identify as high need, but they do, for whatever reason, don't want to participate, you don't actually have a mechanism for investing in the capital capacity that you need in the places often that you need it most. And one of the things that we do have at the moment is we do have a disparity between where the investment goes in terms of capital and where it's most needed. And some of our more deprived communities have some of the worst primary care capital investment. So there's something needs to be looked at in terms of the relationship between the GP contract itself and the way in which you can incentivize GPs to participate in funding programs to get the capital developments in the right places. The third point is I think systems need some flexibility around capital. So one of the things that we've had recently, which is now finished, was something called the ETTF scheme, which is the Estate Technology and Transformation scheme. The advantage of that is it gave flexibility to systems to target small sums of investment into where they felt it was needed most. So you were able to build an extension on a practice or build an extension on a community centre. And we find that those types of investment actually deliver very high value for money. They you get they're roughly 75% cheaper than other forms of investing in estate because you're building on existing estate. So that the ETTF scheme is finished, and I think this new investment plan ought to create some flexibility for systems locally to determine how some of the capital funds are targeted to support localized development. So that's the third point. And then the fourth point, which is kind of, it's really how linking this into the kind of wider planning agenda. So we have flexibility through Section 106 planning arrangements with local authorities when you have in new housing developments to secure some of the development funds to support NHS capital investment. Those sums of money are never enough. It's only a contribution. So again, that's why I think systems need flexibility to for capital to build on top of that development pot. But also one of the challenges with that opportunity in terms of working with councils is that, of course, again, going back to the health inequalities agenda, the more deprived communities, more deprived areas generally have a much lower rate of return on those developments. So actually the amount of money that's available to support investments in the more deprived areas is considerably lower. So again, that exacerbates the health inequalities challenge. So summing up, I think one of the things that we need to look at is how do we generate more flexibility and how do we change some of the current rules so that we can ensure that capital development goes into some of those communities where we have the biggest inequalities in health.
Thank you very much, Paul. Without further ado, we shall move over to Professor Jane Perry.
That's great. Mike, are we going to use the slides or not? I'm happy to talk with that. We are going to use the slides. Thank you. Thank you for the opportunity to come and talk today. Obviously, I'm going to be talking from an educational perspective. We've heard a lot about the pandemic, and I think actually the future of how we educate our practitioners will also need to change based on some of the really innovative and transformative learning that's taken place during the pandemic, but also the sort of solution-focused approach that we had with our practice partners during this time, because it was very challenging times for everybody. Have the next slide, please. So when we talk about the estate, I mean, I was really fascinated by this because we're now developing a new hospital and primary care training hub, because it's becoming really apparent that we mustn't train students in silos. They need to have a very, very full and holistic patient journey. So what does that look like in the new world, and what does that look like in the digital world as well? And we do, I'm at the University of East London, where which is an area where there are large health inequalities, and actually providing a sustainable healthcare workforce is really, really important in this area for us, as I'm sure it is nationally, but it really is important, and producing career-ready practitioners is going to be even more important moving forward. So we do want our students to be able to work interprofessionally. Again, practitioners and professionals often do train in silos, and although we talk about interprofessional learning, I don't think we're still doing it well enough to produce the kind of strong integrated teams that we're going to need moving forward, and that we need now to address some of the challenges that we've got with workforce crisis. And I'm very lucky. I've got a School of Health, Sport and Bioscience, and during the pandemic I've seen where every single one of those practitioners can come in and make a difference. And the important thing now is actually for other practitioners to see how that works together, the power of science, the power of sport, and you know, alongside other healthcare practitioners. And one of the things we did in the pandemic, which I think is really important, is we grew very strong relationships with our practice partners, and start to co-produce how we would manage the student journey. And so really, you know, good academia moving forward is practice partners, service users, academics and students, all with a very strong voice about what healthcare infrastructure and what healthcare roles should look like moving forward. A big passion of mine is pioneering new roles in healthcare and new ways of working, and I'm a big fan of the new role of the physician associate and many other advanced roles and different roles that are still very little understood, and the importance of health over illness and prevention over cure. And I think something else we need to consider is that actually we have a divide between people who work in the education sector and those that work in clinical practice. And if we really want to develop strong innovation in learning and teaching and good practitioners, strong practitioners, we need to think about how we develop better clinical academic careers. So in effect, you know, maybe looking at even your level 6 students that might want a career in education and working out how you nurture that and still keeping them clinically sound. Medicine are very good at that. I think with nursing and allied health and other professions, we need to work harder on that. So we need to look at a new educator for the future as well. Can I have the next slide, please? And just want to talk a little bit about some of the new roles, because I think we do talk a lot about nursing and doctors, and we have a whole plethora of new roles that are really, really fantastic. And but some of them are little understood. They're starting to appear in workforce modelling, but they're not really embedded in it, and they haven't really evolved as much as they can. But when we have the real challenges of not enough doctors and not enough nurses, it would be really important to think differently about where we can use some of these practitioners. I mean, the role of the physician associate is a very exciting new role. It's not well understood generally, although in pockets where it's used, it's very well understood. But this is an advanced practitioner who works under the supervision of a medical practitioner, but works in the medical model, and you know, they're very generic practitioners who would be really well placed in general practice, for example, but they're very well placed everywhere. And I think when we're thinking about remodeling the estate, what should new general practice look like? You know, some of these roles are obviously in general practice now, but just as one example. And the advanced clinical practitioners, you know, you take a nurse or an allied health professional and they take advanced training to be able to prescribe and do advanced clinical assessment. And then we know we've got lots of pharmacists. There's an oversupply of pharmacists and an undersupply of other professions. And you know, pharmacists know more about prescribing and medicines than any of us. So how do we utilise those roles better? And although we are seeing some of that. And then the role of the nursing associate, which is a new nursing role, which again is not very well understood. But again, this really brings back a new level of nurse that really is complementary to the registered nurse and can really help with workforce challenges. And we talked a lot about public health, I was just saying public health, sport, psychology. You know, universities bring out lots of public health practitioners, lots of psychology students, and lots of sports therapy and clinical exercise scientists and And where are we using those to support public health, to support long-term conditions? This is all about thinking differently. And then the power of apprenticeships across all professionals. If you want sustainable local workforce, apprenticeships are often a really good way of doing that. And that's really evolving now across all the professions: nursing, allied health, public health, healthcare science, etc. And we're now seeing this in medicine as well. And how do we develop and work, co-create career passports for promotion and portfolio careers? People do know they want to stop on and off careers. And how do we do that in a widening access way to make sure that it's research-informed learning and teaching? We have global and inclusive curriculums and equity of training opportunities. And this also includes tariff, which is not always equitable across professions. Next slide, please. And really just what could the future look like? I mean, that's a very small slide, so but it just is there to give an example of all the different disciplines that we could use to really support a future healthcare infrastructure moving forward. And it is about thinking differently. It is about diversification. It is absolutely about staff development and bringing forward understanding around the power of simulation, disruptive technologies, so that we actually do produce graduates who have those digital skills. But we also support the staff who will also need to development in this area to be able to move forward with this. And that we do develop a transformative future workforce with high caliber, competent practitioners across all fields, with high performing graduates that actually have the right knowledge and skills. And we do that through co-creation, through working together, and through actually being very clear about what the future should look like. And so for sustainability, we need strong partnerships, collaboration, shared vision, and working together. And just to finish on, really, one of the things I do remember about the pandemic is devolving our students into frontline clinical practice, and that fantastic working that has been so important, but also working with Health Education England around the work with NHS Nightingale, where some of our staff were deployed. I think we can do so much great work together, but it's a very, very big cultural shift and move that we're looking at.
Thank you very much, Professor Perry, and a special note actually as well, because we know you were just back off holiday yesterday, so thank you so much for putting together those slides so quickly for us as well. We are now on to our final speaker. We'll hand over to Richard Darch from Archus, please.
Thanks, Mike, and good afternoon, everybody. Unsurprisingly, I'm going to agree with every point made so far by the previous three speakers. But certainly a sort of commonality of thinking, but perhaps just to pick up on some of the points made, and I guess I would have a single point to make, which is that we need to rediscover planning in the NHS. And this is, I think, a lost art and science across the NHS. The NHS historically has led the way in the way in which it planned its services and indeed its capital allocation across the system, and we've moved away from that. And although the title of this particular seminar and this meeting is around a refresh of the health infrastructure plan, I'm not sure if we need another health infrastructure plan as such. We need a strategy for capital investment, and I use the word investment, not spend. Because it is an investment. You do get a very real return on that investment, and we should have the rigor and the discipline and the approach to measure that return on that investment, because it does lead to improved services, which in turn leads to improved health outcomes. In terms of comparisons, Mike, I don't know if you put up just a couple of slides here, really, with some stats and won't bore you too much with this, but I think there's a few which illustrate this very well. There just hasn't been enough capital investment and enough capital in the system in the NHS. We've seen a gradual decline to the extent where the NHS and the UK lags behind developed health systems across OECD countries. With the blue line there, you see in terms of the UK over that 16-17 year period, way below the average. Next slide, please. And this, again, another rather sad picture in terms of the UK compared to OECD countries. And we're being half of that of places such as Australia. So I see the point about how it's used as well as the amount of capital. And I think there is a positive picture in terms of how capital is starting to be used. If you go on to the next slide, Mike. Which actually is a more positive picture in that it shows that if you look at capital spend on technology, and this is capital spend per whole time equivalent, so per worker, it's actually increasing, and we're seeing quite rightly a reduction in spend on things like land, and to some extent on buildings, but IT technology going up. So that's a positive, and that's a positive trend. But I would still suggest that in terms of overall quantum, particularly as you see it as an investment, it is not sufficient. It is not sufficient, certainly, to deliver the sorts of changes that Paul outlined in terms of the move of services into primary and community settings, to be able to support and invest in disadvantaged communities. We don't have the planning mechanisms to support that. And our approach has been very much over the last 10 years, whilst, well, perhaps actually longer, over the last 20 years, whilst we've been in a competition-based landscape for healthcare, that has led very much to a bidding environment for capital. So even Paul's mention of the ETTF, that's about putting in a bid and getting a response back to a bid, putting in a business case and getting that approved or not, putting in a bid for the new hospital program and getting that or not. Well, I would suggest that it should not be about a bidding process, because it should not be about just the quality of particular presentation or business case, and it politicizes too overtly the flow of monies and flow of capital, because individual cases are made. And if I go back to my point at the very beginning in terms of making the case for planning and having more robust strategic planning across the NHS, where we can establish where the investment priorities are across the NHS, how they can best be met, whether it best be met through capital or investment in workforce, which is clearly an absolute priority, technology, and then finally in terms of the buildings that at the end of the day are a wrapper around the people in the technology. So it's getting the workforce and the technology right, and then understanding the wrapper that you put around that. And through that planning approach, not only will that give visibility to individual communities and health systems in terms of their investment requirements and how they can be met and how they can be prioritized, but also gives visibility to external players in this, in terms of the construction industry, that with that visibility can actually tool up to be able to meet the requirements for longer term programs of investment rather than this bidding approach. And also, again, to Paul's point about primary care, there are plenty of pools of capital and pools of money out there that could support investment in that type of asset, particularly in pension funds and other appropriate pools of capital that could be accessed to, as I say, to deliver those assets. So it's not about one size fits all or one approach, but understanding what type of asset will attract what type of capital. So that was my points really, which is the single point to improve and rediscover planning. Thank you.
Thank you very much, Richard. That was a fascinating presentation. So we are now on to our question and answer. You can see that our chair has flagged in the chat that if you're interested in asking a question, could you please raise your hand just to indicate. I'd like to call on, see if any parliamentarians on the call would like to ask any questions first. Have a look. Not that I can see. Do any of the other participants on the call would like to ask a question at all? Any of our speakers? Or Baroness Masham, we have your hand up. Yes, I'll hand over to you.
I just wanted to ask, it was very interesting. Keeping up with other countries is very important. What about the equipment, upgrading the equipment? Because I know that some people will come and work in hospitals that are updated and have good equipment, and others have struggles.
Okay, thank you, Rich Masham. I'll go to each of our speakers in turn. Can I start with Professor Perry first, please, if you've got anything to add on this, Jane?
I think it's a really valid point, because actually what we're talking about doing here requires absolutely huge investment. So I'm talking from an educational perspective. If we want to try and mirror training that supports practice, then we need good high-tech equipment to be able to manage that. So I think nationally or university would say this is resource intensive and very, very expensive, particularly if you want to be current and topical. So funding and support are clearly areas that we're all very keen on, because it's very expensive.
Thank you, Professor Perry. So Chris, do you have anything you'd like to add on this one?
Yes, I mean, we saw early in the pandemic, didn't we, the challenges we had around ventilators in particular, and then the government responding with the challenge program to increase the supply of ventilators. But beyond that, if you look at the OECD data, we have fewer CT scanners, MRI scanners in this country pro rata than other European countries or countries comparable with us. I mean, the good news, if it is good news, is there is now an investment in diagnostics in particular, the program with the community diagnostic centres that are beginning to become up and running now in all parts of the NHS. And it's not just buying the equipment, it's also making diagnostics more accessible to patients and to the public in community settings, often in high street premises. And yeah, that has to be a step in the right direction. But I think the point that's been made by Richard, what we need is to rediscover the value of planning, and not just capital planning, but service planning based around populations. This is what the integrated care systems are beginning to do as part of the current reforms, and the Health and Care Bill will make them into statutory bodies. But we shouldn't declare victory too soon, because they're still in the foothills, really, of the work we expect them to do in future. But yes, the capacity must include looking at equipment of all kinds and how that equipment is used, where it's located, from a patient and a population perspective, not just from a service provider perspective.
Thank you very much, Sir Chris. Richard, do you have anything you'd like to add on this?
Just a point really, that absolutely investment in equipment, but also to make a plea for the maintenance and replacement of that equipment as well. So it's not just about the capital. About 10 years ago, just over 10 years ago, there was quite a significant investment in cancer equipment, in linear accelerators, but the maintenance and replacement budgets did not follow on. So we've now got a lot of aged linear accelerators all coming to the end of the life at the same time. So my plea would be to have an ongoing replacement budget, as well as the capital to acquire it in the first place.
Thank you very much, Richard. And Paul.
Yeah, well, better equipment delivers better outcomes. I mean, if I just take my patch, one service, urology, we have people choosing to wait longer for the urology service at Wolverhampton Trust because they use a robot, and by using the use of the robot, they deliver better outcomes. So that, and I think we therefore need, we would do better by having more transparency and more in relating the use of investment to outcomes, and demonstrating actually the variation in outcomes that arises from that, because I think that would create an impetus for ensuring that we're getting the investment into the right places. The other point to kind of reflect on that, though, of course, is that not just in terms of the upkeep of equipment, but then actually ongoing and training development of staff. Because if you're going to keep up with the pace of improvements and new technological opportunities that exist, you've got to invest more in training and development. And that's I'm sure I read somewhere that 80% of health service training and development goes into people's initial training in the first various stages of their career. If we're going to have a truly effective service which is up to date with all the use of technology and equipment, then we need to be putting more resources into training our staff to be able to use them effectively.
Thank you very much, Paul. If you have a question you'd like to ask, please raise your hand in the chat window as well. We've had a question on the chat from Claire. So she says, so Chris highlighted staffing as one of the key issues facing the NHS. Are we recognising sufficiently the role of the NHS estate in helping to address this? And she draws her attention to the report published last week by the King's Fund on the implementation of additional health professional roles, such as social prescribing and clinical pharmacists, excuse me, in primary care. So Chris, given that point was addressed to you, would you like to respond first, please?
Well, I think Paul made the point in his opening remarks that this is another aspect of planning, isn't it? Thinking ahead to where do we want care to be delivered in future, given the technological developments, the needs of the population, and particularly in the current climate, our aging population, the concerns about multi-morbidity, which ought to be addressed first and foremost in a primary care setting, but GP practices working together and working with a wide range of health services staff in the community, AHPs, nurses, and social care staff included within all of that. So if we're going to address the staffing challenges, which I think was what Claire was highlighting, we need to make the investments in building and equipment and other infrastructure appropriate to the needs of the future, not just looking through the rear view mirror where we've come from. And having attractive buildings that are good places to work in, as well as good places to be treated in, is part of that.
Thank you very much, Sir Chris. I can see Claire was nodding along with that as well. Do any of our other speakers want to come in on that point at all? Professor Perry.
Can I just come in very briefly, because I think it is about navigating patients to the right practitioner. Sometimes, you know, the journey is quite long to get to the person that you need to see. So, you know, you have to see a GP and then you get a referral to somebody else, for example. You know, if we were able to use some of the great learning from places like Bromley by Bow, where they really do a lot of work around social prescribing, and I'm sure lots of other areas do. It's really powerful work that they do, and they create really good communities for patients and reduce the number of people who are actually coming in to see a GP. So I think it's about really thinking about how you navigate a patient to the right practitioner so that they actually get the help that they need.
Paul.
Yeah, I'm just going to, thanks. I'm sorry, I don't know how to put my hand up on Zoom. I'm just going to, I used to using Teams. I'm just going to just re-emphasize the point about health inequalities again, because and the point about planning, actually, because I think we are actually getting, there's a lot of investment going into new roles, particularly out of hospital in health coaching and physios, more pharmacy, etc. But we've got a mismatch between available capacity and the people, in that we don't, because of a lack of long-term planning and because of the issues I raised earlier about not being able to necessarily target capital development in the most deprived places, we very often have an insufficient, a shortage in physical infrastructure to be able to house those staff. So we may have enough resources, enough space overall, but the space is in the wrong places. And so that, I think it re-emphasizes Richard's point about the need to have a proper strategic planning approach to capital development.
Thank you very much, Paul. I will make sure. So, would any of our speakers like to come in on that point at all? Anything else to add?
I think the only thing I would just add very briefly to Paul's point is, it's back to what I said earlier about investment. You know, it's not about capital spending; it's about capital investment, and investing in infrastructure is an investment in staff as well. Actually, working in a nice environment is important, and good employers recognise this, and the NHS should be no different.
Thanks very much, Richard. Again, if you'd like to, you can put your hand up on camera if you want, or you can raise it virtually in Zoom, or put your question in the chat if you'd like to. we have had a question from Kate Edwards as well. Kate says, we've talked a lot about workforce training and equipment. Should we also be talking about infrastructure such as key worker accommodation? Is there a need to make the sector attractive to people to come and work in the NHS and social care? Would any of our speakers like to come in on that one? I say, well, I shall pick on Paul first this time round.
So, I mean, actually, when I started my career back in 1990, I was working for Oxford Region, but I was allocated a space in the nursing accommodation in the hospital I was working, and it was really important actually because I know it's really important for particularly students in the health service to be able to have affordable accommodation. Particularly in, I mean, you'll know, particularly in the larger conurbations and in the southeast, that's really important. So regardless of the kind of potential need for this to support recruitment from overseas as well, which is obviously an issue, I think actually, there's a whole issue in this, isn't there, about affordability of accommodation for our public sector workers. And you've got to, that's got to be a factor that needs to be given some consideration, I think.
Thanks so much, Paul. Richard, do you have anything you'd like to add on this at all?
No, well, I think again, I should pick up on some of the points made earlier that there's no one solution to the requirements and some of the deficiencies around capital investment, and there are different models for different types of asset, and key worker accommodation is a different sort of asset, and there are plenty of funders and developers that would be able to deploy their capital and their expertise to deliver that type of asset and infrastructure very, very efficiently if they were aware and had visibility of the demand and the need. And we've seen this in the university world. If you go back again a number of years, then universities would have had to have given absolute guarantees over the occupancy of those facilities. But now they are so comfortable with the market that they will invest themselves, build it, and they will come. And we need to give that same level of confidence in the healthcare setting and in social care as well. It's not just health, it's social care. Also for community carers, that we will support and support them in housing and provide financial support in housing. Then the investment will follow.
Anything to add, Professor Perry?
I was just going to say I think it's quite a very important point, really, because one of the recruitment issues that we have in London is such an expensive place for people to live and work, and a lot of healthcare professions, the challenges of living and working in London on their salaries is really huge. So I think it is a significant issue in terms of being able to support and help people moving forward. And one of the reasons why we developed and did so much work, locally with our local trust with local people, because they just weren't retaining any workforces locally, because people would come to London, get trained, and then go back to where they lived, and that wasn't actually supporting the local trust. So I think it's a valid point.
Thank you, Professor Perry. So Chris, would you like to add anything on this question? Okay, thank you very much. I see Tom Bell has his hands up. Tom. Oh, sorry, Tom, you're on mute. Could get through a meeting without it happening once.
Gee whiz, yeah. You'd think 2 years on Zoom and I'd have avoided that schoolboy error, wouldn't you? First of all, thanks for inviting me, Mike. It's greatly appreciated. So I think if I can just throw a couple of loose thoughts up in the air. Everyone in the room is doubtless familiar with the Drucker phrase that culture will eat strategy for breakfast, yeah? And so I speak as an ex-public sector employee, 5 years in NHS middle management, and as a former private sector employee and a business advisor. And I speak as a Cumbrian. So the Cumbria perspective is really interesting, because when Jane talks about people leaving London and coming back, none of them came back here, unfortunately. We've been listed as having one of the most challenged, I think is the polite way to put it, healthcare systems in the UK. We were one of the 3 success regimes that some of you may recall. And there's something, isn't there, about let me bring this to life. So when I was working in Carlsberg, and then I contrasted that with my time spent in the NHS, I worked for an employer, a large Danish brand, that managed to motivate and retain staff more effectively in the service of selling sugary alcoholic liquid to the masses than the NHS could in terms of delivering healthcare. And there's no simple answer to this, and culture is the one thing that we all know needs to change, but we all struggle with addressing. But how is it that we reached a point where, if Ruskin was right, and I think we probably would agree that he is, that there is no wealth but life, then how did we reach a point where, as soon as a Sainsbury's opened up just down the road from the Cumberland Infirmary in Carlisle, the hospital lost all its healthcare assistants because they would rather stack pot noodles on shelves at night than subject themselves to the management cultures of the NHS? You know, how did we reach a point where we have the greatest, what many people consider to be the greatest innovation in the world, the National Health Service, one of humanity's best achievements, not just one of Britain's, in my opinion, where we have 100,000 vacancies and we struggle to fill those, and we have huge turnover in leadership and management posts, and we have cultures that continue to blame rather than learn. And with respect to everyone in the room, unless we address that elephant in the room, then whatever you invest in tech, and I've seen tech invested in Cumbria, and we've seen a new cancer facility invested in Cumbria, but we can't get people to actually staff the services.
So Tom, your question would be about staff retention and management culture transformation.
Well, transformation, if I can just kick the transformation out, because we've been trying to perform transformations since 1066 and it hasn't worked. So if we want to talk about evolution or development or whatever you want to change, but there's something that needs to change culturally within the NHS if we're going to make it the kind of place to work that people have been describing as a place that values its employees.
I'm very sorry, I'm going to have to cut you off there.
No, that's fine, that's okay.
It's a fascinating discourse. We've just got a few more questions to get through as well. Can I ask any of the panel if they'd like to respond to that particularly issue about how healthcare estates and infrastructure policy can relate back to workforce retention within the NHS, please?
I mean, I think partly, if I kick off on this, let's not underestimate the importance of pay. And that's going to be a challenge for all public services. And if we don't get that right, the challenges that we've just heard about will become greater. Secondly, I think it's about offering as much flexibility as possible in terms of how people work and how they want to work, and recognize the NHS has made some progress on that, but there's a lot further to go. And then the third point, which I think was the core one behind the question, it's about creating the culture within healthcare organizations that really do value staff. We talk about it a lot, and some organizations do it incredibly well, but there's too much variability at the moment, and that can't be right.
Thank you, Sir Chris. Do any of the speakers want to come in on this one at all?
Well, one thing I'll just add very briefly, I think I absolutely agree with the point on pay. I think also in my experience and with good employers is to give people control over their lives and as far as possible to look at ways in which technology can be used to give people that control in terms of choosing their hours, choosing their work patterns, because that control I think is important as well as the financial reward.
Does anyone else want to come in on this point at all? Okay, thank you very much. We are moving into the last 10 minutes. So we've still got a few questions, so I'm going to group these because I'm a parliamentary procedure nerd. So we've had a question from James Bourne from Community Health Partnerships. What is the panel's view regarding the one key aspect they would focus away from investment in the acute sector to investment in the primary and community care sector on the delivery side of things? We've had a question from Jackie about, basically she's talking about system infrastructure failure in Lincolnshire. So they put in 3 bids there relating to health inequalities, bit of capital investment there. She says they'll need approximately £2 billion across acute, community and primary care over the next 15 years to make sure that happens in the right place. So how could the refresh of HIT look to tackle those health inequalities within the regions? And then we've got Nicola saying that one of the great takeaways from COVID was how the NHS, showed how the NHS could use its ability to better use data analytics and allocate resources as needed. And I know that, that as you can see, Lord Bethell's providing some commentary in the chat as well there. Perhaps we could ask the panel for their views on how the refresh of HIP should drive the investment in technology and what those areas of investment in digital transformation and tech need to be through HIP. And if I could go to Richard first, I'm happy to recap any of those questions if needed.
I'll also try and group them. But really on the first, on James's and the point, and Jackie's also on focusing on Lincolnshire. I think they're sort of related in terms of, well, we've got a plan, and we want to invest in a different or deliver a different configuration of our infrastructure, recognizing the health trends that are in front of us. So that's a sort of potentially over time, perhaps a divestment from acute into community and primary care. I think that the issue they're facing there is one I mentioned earlier, of this challenge of it being about bidding all the time rather than a long-term journey. And I'll go back to the university sector. It was many years ago, you had seen a single university on the hill in a town or city. Now a university and its buildings and its presence is endemic throughout the town, throughout the city. There are there's a campus, there's several buildings, there's key worker accommodation, and this is the way I think we need to look at healthcare and infrastructure and technology. That it's not about a single solution, not about a single panacea of a new building, whether it be a hospital or a primary care centre. It's about a plan. It's about a plan that matches workforce and technology and the wrappers that you place around that, and it's over a longer period. It's not just about a single bid. That 2 billion, yes, it seems a lot of money, but over 20 years, it's it's a more manageable sum, and you see it as a refresh rather than focusing on the panacea. So it's about developing a culture of delivery and a culture of planning, in my mind, with the systems, processes, and the allocation of monies, whether it be capital revenue to support that.
Thank you very much, Richard. And can I go to Sir Chris next, please?
Well, let me just pick up the question that I think Nicola raised about the use of data during the pandemic and the take-home message, as I understood it from that, to really violently agree with her point here that the vaccination program in particular was a great example of how, for the first time almost, we were able to integrate data from different sources around the population, identify the groups that were not taking up the offer as rapidly as others, find different ways of reaching out to them, and achieve huge success through the vaccination program, which has then stood us in good stead in the last year or so. If we can do it in wartime for something like vaccination, why can't we do it in peacetime for all the other big preventative priorities that we face, targeting people, and this is back to Paul's point about inequalities, targeting the groups in the population, cardiovascular disease, from cancer, around early diagnosis, and then early access to the forms of treatment that will help them and hopefully enable them to survive in good health. And that needs a really strong infrastructure of data and skill in using data. And during the vaccination program, this is really a public-private partnership where the private sector worked very, very closely with the NHS, with local government, to be able to deliver that sort of result. So let's try and do this now as we move forward in these other areas of population health priority.
Thank you very much, Sir Chris. Paul.
Yeah, just one general point. I think so the revenue funding that we get in the health services is linked to deprivation factors. It's weighted. Capital investment isn't. So if we want to try and address the inequalities, then actually finding ways to align the capital investment and the revenue investment together so that you can then plan for it better, I think has the greatest potential of reaching, delivering real dividends. I I think we've learned. I do agree with Chris about the data. I mean, I think we've learned a huge amount during the pandemic, and actually people have made decisions, and we've made changes very quickly. If you think about the whole shift to online, shortly before the pandemic, we were being encouraged to develop online solutions for primary care. We were looking at 3-year time horizons to have it implemented. It ended up being implemented in 3 weeks. So, I think the skills and capability to really deliver real improvements exist. It's just where and how do we generate the will and motivation within the services to continue to innovate those changes at pace. Really, I think that's one of the cultural questions I think we need to consider.
Thanks so much, Paul. Professor Perry, anything to add?
And not much really, other than I think it would be a shame if we lost the innovation that we've seen, and that we revert back to type, and that we do actually move forward and embrace some of the changes. I, as somebody who is late in my career now, am absolutely blown away with what technology can do. I've seen things through AR and VR technology that I have never seen in clinical practice, and I would be so well prepared as a student if I had that experience as preparation to go out. So I think it is really important, but also the culture and values of staff are really key as well.
Fantastic. We have a couple of minutes left. There's one area that I think we've had one question on, which is relating to net zero. So very quickly, could we just ask each of the speakers, what do you feel needs to be set out in the refresh of HIP that is going to carry the NHS towards the ambitious pledges made by the Health Secretary at COP26 last year to have the NHS lead the world in reaching net zero? Can I go to Sir Chris first, please?
Well, the honest answer is I don't know if there is one thing, because this is such an important and highly complex area, isn't it? And the NHS at the moment, in my experience, is embracing a whole range of different changes, interventions, improvements in relation to anaesthetics, drug use, transport, and so on. I have some great examples. I was listening to Jackie Daniel, who's the chief exec up at Newcastle of the Foundation Trust there. Their approach is very much embedded in a wider public sector approach to net zero, working with the local authorities, working with the universities, and learning from each other. Maybe if there's one thing, it's we need the NHS to embrace that sense of partnership with others in their communities and harness all the assets, all the expertise we've got.
Paul.
Yeah, maximise the potential for people to be treated to maintain their own health in their own home, and wherever possible, if they have to go somewhere, to see someone, see them as locally as possible. Because I think one of the biggest contributions that the NHS makes to the cost of the climate change, etc., is the carbon footprint associated with travel. Everyone traveling everywhere, actually, if we can use new technology, if we can make sure we get the right balance investment between primary community services and secondary care, we can minimise unnecessary travel to facilities, when it should be completely avoidable. That would make a massive contribution to reducing the carbon footprint.
That's great. Thanks, Paul. Professor Perry, anything to add?
And just agree with what's been said, really. I think there are some excellent innovations going on. I know I went to a conference recently where they talked about some of the wonderful things that we're doing. So I think it's just about how we disseminate that good practice, because it's really key agenda for us, everybody.
Richard?
Well, just the one point is build less. The greenest building is the one you've already got. It's about repurposing and building less. To that point, with the focus too much, I think, on hospitals and delivery of new hospitals. Hospitals, we tend to warehouse warehouse a problem, because we're not sure how to deal with the problem, so we wrap a warehouse around it rather than thinking about the technology and the type of asset we need throughout a community to be able to address health needs. And the final point is on Paul's, that 3% of all car journeys are NHS related. That's a lot of car driving that's related to the NHS.
I've learned something new there. Just wanted to say, Lord Bethell says, thank you very much to all speakers for attending. Great job. So thank you all very much for attending today. It's not often I get to sit and do this as well, so it's been nice, and thank you for indulging me. A couple of quick parish notices. So the next meeting of the All-Party Group will be held on Tuesday, the 17th of May. It'll also be the date we are launching our call for evidence on the short, medium and long-term needs of healthcare infrastructure. We welcome submissions from you all and from any interested parties on that as well. We'll be looking across the piece on this as well. It's going to be our first report that will be out before the summer recess in June. Congratulations again to Lord Bethell on election as Vice Chair, and thank you all very much for attending, and we look forward to seeing you next time.